this lecture, we are going to discuss thyroid eye disease. We are going to discuss the treatment of the disease. Treatment can be classified into that of mild disease, which is most of the patients, moderate to severe active disease, and treatment of post-inflammatory complications. The first measure taken in all cases should be the cessation of smoking. Thyroid dysfunction should also be managed adequately. If radioiodine treatment is administered in patients with pre-existing thyroid eye disease, a short course of oral steroids should be given in concert. Now, first of all, we will be discussing the treatment of mild disease. Lubricants for superior limbic keratoconjunctivitis and corneal exposure and dryness. Then topical anti-inflammatory agents, be it steroids, non-steroidal anti-inflammatory drugs, or cyclosporins, are advocated by some authorities. Head elevation with 3 pillows during sleep to reduce periorbital edema, and eyelid taping during sleep may alleviate mild exposure keratopathy. Towards moderate to severe active disease, which is where clinical activity score by European Group of Graves orbitopathy or UGOGO suggests calculating a clinical activity score to aid in determining a threshold for the use of immunosuppressives, assigning 1 point for each feature present from the following list, and considering treatment for a score of 3 or more out of 7. So number 1 is spontaneous orbital pain. Number 2 is gaze-evoked orbital pain. So first 2 are related to the orbit. Number 3 is eyelid swelling considered to be due to active inflammatory phase of thyroid eye disease. And number 4, eyelid erythema. So these 2 are related to eyelid. Number 5 is conjunctival redness considered to be due to active inflammatory phase of thyroid eye disease. And chemosis is number 6, and finally inflammation of caruncle or plica. So last 3 are related to conjunctiva. So during subsequent review, a point is allocated for an increase in proptosis of 2 millimeters or more, a decrease in ocular excursion in any one direction of 8 degrees or more, or a decrease in Snellen acuity of 1 line. Systemic steroids are the mainstay of treatment for moderate to severe disease. Oral prednisolone 60 to 80 milligrams per day may be given initially and tapered depending on the response. Intravenous methylprednisolone is often reserved for acute compressive optic neuropathy, but tolerability is better and outcomes may be superior compared with oral treatment. A lower intensity regimen in the absence of acute sight-threatening disease is 0.5 grams once weekly for 6 weeks, followed by 0.25 grams once weekly for 6 weeks. A reduction in discomfort, chemosis, and periorbital edema usually occurs within 24 hours, with a maximal response within 2 to 8 weeks. Ideally, oral steroid therapy should be discontinued after several months, but long-term low-dose maintenance may be necessary. Then orbital steroid injections are occasionally used in selected cases to minimize systemic side effects, but are typically considered less effective than systemic treatment. Low-dose fractionated radiotherapy may be used in addition to steroids when steroids are contraindicated or ineffective, but because of delayed effect is not used as a sole treatment of acute optic nerve compression. A positive response is usually evident within 6 weeks, with maximal improvement by 4 months. Around 40% will not respond. Adverse effects include cataract, radiation retinopathy, optic neuropathy, and an increased risk of local cancer. The threshold for its use should be higher in younger patients and diabetes, the later because of a possibly increased risk of retinopathy. Combined therapy with irradiation azathioprine and a low-dose prednisolone may be more effective than steroids or radiotherapy alone. Immunosuppression in active inflammatory phase of thyroid eye disease is important to reduce acute inflammation and to prevent long-term complications. Uh, Optic neuropathy and less commonly intractable corneal exposure requires aggressive treatment. Pulsed intravenous methylprednisolone is commonly used. Regimens include zero point 0.5 to 1 grams on 3 successive days with conversion to oral treatment, for example 40 mg per day prednisolone, or zero point 0.5 to 1 gram on alternate days, 3 to 6 times, keeping the maximum dose below 8 grams to reduce the risk of liver compromise, followed by oral prednisolone. Appropriate monitoring should be instituted, including liver function test, as well as gastric protective treatment and osteoporotic prophylaxis if necessary. Orbital wall decompression and/or orbital apex decompression may be considered if steroids are ineffective, which is 20% receiving the intravenous treatment, or contraindicated. Orbital radiotherapy may also be administered, but is generally only used as an adjunct to other modalities. Several drugs targeting specific aspects of the immune response in thyroid eye disease are under investigations, notably monoclonal antibodies, especially with rituximab and teprotumumab. Now, teprotumumab is an inhibitor of insulin-like growth factor 1 receptor (IGF-1R) and is effective in reducing proptosis and the clinical activity score in patients with thyroid eye disease. Post-inflammatory complications then we have to manage post-inflammatory complications, which include eyelid surgery, which should be done only after any necessary orbital and then strabismus procedures have been undertaken, as orbital decompression may impact both ocular motility and eyelid position, and extraocular muscle surgery may affect eyelid position. Proptosis after active inflammation has remitted. The patient can be left with cosmetically and functionally significant proptosis, the treatment of which is essentially surgical. Surgical decompression increases the volume of the orbit by removing the bony walls and may be combined with removal of orbital fat. Most surgery is undertaken via an external approach, though the medial wall and the medial part of the floor can be reached endoscopically. One wall, which is deep lateral decompression, is effective approximately 4 to 5 millimeter reduction in proptosis and may reduce the risk of postoperative diplopia. Two-wall balanced medial and lateral decompression provides a greater effect, but with a significant risk of inducing diplopia. So while considering that surgery, it should be kept in mind. Uh, Three-wall decompression includes the floor with a reduction in proptosis of 6 to 10 millimeters, but may lead to hypoglobus and carries a higher risk of infraorbital nerve damage and diplopia. Very severe proptosis may require removal of part of the orbital floor in addition to that, and it is called four-wall decompression. The picture in the CT scan here shows two-wall decompression. Uh, you can see bilateral, lateral, and medial walls are absent, and only the nasal bones are present here. So, moving on. The next post-inflammatory complication is restrictive myopathy. Surgery is required in most of the cases experiencing persistent diplopia in the primary or reading positions of gaze, provided the inflammatory stage has subsided and the angle of deviation has been stable for at least 6 to 12 months. Until these criteria are met, diplopia may be alleviated if possible with prisms or sometimes botulinum toxin. The goal of operative treatment is to achieve binocular single vision in the primary and reading positions. Restrictive myopia often precludes binocularity in all positions of gaze, though with time the field of binocular single vision may enlarge as a result of increasing fusional vergences. Recession of the inferior and the medial recti is the most commonly indicated surgery. A rectus muscle is never resected, only recessed in thyroid eye disease, generally utilizing adjustable sutures. The suture is adjusted later the same day or on the first post-op day to achieve optimal alignment, and the patient is encouraged subsequently to practice achieving single vision with a considerably accessible target such as a TV. Then comes the lid retraction. Mild lid retraction frequently improves spontaneously, so does not require treatment. Control of hyperthyroidism may also be beneficial. Botulinum toxin injection to the levator, aponeurosis, and molar muscle may be used as a temporary measure in patients awaiting definitive correction. Mollerotomy, disinsertion of molar muscle, is effective for mild retraction, but more severe cases may also require recession, disinsertion of the levator, aponeurosis, and the sensory ligament of the superior conjunctival fornix. Recession of the lower lid retractors with or without a hard palate graft can be used when retraction of the lower lid is 2 millimeters or more. So this is where we are concluding the treatment of the thyroid eye disease. Uh, if you like the lecture, please press on the like button and subscribe to the channel. Thank you very much.